All right, so I'm going to be introducing Dr. David Suskind. He is a pediatric gastroenterologist at Seattle Children's Hospital, where he's also the director of clinical gastroenterology. He's a professor of pediatrics at the University of Washington School of Medicine. He did his residency at New England Medical Center in Boston and a fellowship at the University of California in San Francisco. He's an expert in inflammatory bowel disease. And he's leading a national effort to study the effects of diet in inflammatory bowel disease with a strong interest to integrate nutritional therapy into clinical care for these patients. He's going to be presenting today on dietary therapy in inflammatory bowel disease from the microbiome and beyond. Thank you, Dr. Suskind. Dr. Suskind, we don't yet hear you.
All right, can you hear me now? Hello?
Yes, we can hear you now.
Okay, wonderful. Well, the first part that I just presented was pretty much the most important part, but we'll still get through this talk. Anyways, it's a pleasure to be here today, and thank you very much for letting me present on, I think, this extremely important topic, the role of diet in inflammatory bowel disease. And I think, as many people know, there was a time in our medical history where we didn't think diet had a significant role in inflammatory bowel disease, and really we looked at the immune system as the major issue that we had to deal with. But over the last decade, we've actually learned so much more from science, including the microbiome and the impact the microbiome has on inflammatory bowel disease, as well as the impact that diet has on the microbiome. And because of this, it has really opened the door into the question of how does diet affect IBD? And so that's what we're going to be talking about today. And we're going to look at both the basic science component of diet in IBD, because I think it's very important to kind of realize how diet is playing a role. And we're also going to take a look at the clinical side of diet's role in IBD. So I want to begin with a young man that I saw a number of years ago and continue to see currently. He presented when he was 14 years old, and he presented with a 3-month history of abdominal pain, loose stools, and weight loss, common symptoms in inflammatory bowel disease. We evaluated him, we got blood levels, and he was seen to be anemic. He had an elevated CRP, which is a marker of inflammation in the body. And so we moved forward with endoscopy and colonoscopy. And you can see here that his bowels, and this picture is a picture of his terminal ileum, is inflamed. It's ulcerated, it's irritated, and this is very consistent with inflammatory bowel disease. And the family, after we spoke, asked me, was there a way to avoid medication? Was there a therapy that would be effective for treating his inflammatory bowel disease and getting the inflammation under control? And this is probably one of the most important reasons for us to really research IBD, because this is a question that is on the minds of, I think, almost every patient out there. There are other reasons that we should also focus on inflammatory bowel disease. as presented already, if you look on the left side of the screen, you can see that IBD is truly an environmental disease. There was a time when the incidence of inflammatory bowel disease was quite low, and that has increased over time. And as pointed out already, this was really at one point thought of as a disease of Europe and North America. But as other areas of the world have industrialized, the incidence of inflammatory bowel disease has increased as well. And again, this points to us to look at what has changed in the environment. And obviously, diet is a big part of that. In addition, this is not only increasing in adults, but also in the pediatric groups as well. And now if you look onto the right-hand side of the screen, you can see another really important reason for us to look at our environment and specifically diet in inflammatory bowel disease. Our treatments are good, but they don't work for everybody. And they don't always work 100% for everybody. And this is just one example. This is a study, a very famous study called the SONIC trial, where individuals were treated with azathioprine or infliximab or Remicade or combination therapy. And you can see that a fair proportion responded by 26 weeks. But again, it wasn't everybody. And this tells us that we need to look a little bit harder at how we can improve outcomes for individuals who have inflammatory bowel disease. And then finally, if you look at the graph at the bottom of the page, you can see that inflammatory bowel disease is not an inexpensive disease. These therapies that we have, while they can be effective for many, are quite expensive. And that has an impact on not only the individual, but also on the health system itself. So these are many other reasons that it's important to look at our environment and look at diet to see how we can improve outcomes and improve people's lives. So to understand how diet plays a role in inflammatory bowel disease, it's really important to understand what inflammatory bowel disease is. What is the paradigm that causes IBD? And as I think many people here know, it's an immune dysregulation. And what that means is an individual's immune system, that part of the body which usually helps us, defends us from infection, has become upregulated and is starting to now attack the bowels. And in health, right, when we are healthy, our GI tract actually lives together with the immune system and the microbiome. And you can see that on the graph on the left-hand side, where the microbiome, the bacteria within our GI tract, the mucosa, that barrier that keeps the vast majority of the bacteria away from the body, and our immune system are all working well together. But something happens, something changes that. And we know that there are a number of risk factors for inflammatory bowel disease. Our genes are an important part, but again, we've had these same genes within our gene pool for millennia. But despite that, inflammatory bowel disease is, again, a relatively newer disease that we are dealing with. So we have to look at environment and what has changed in our environment. Well, antibiotics actually are a big component of that, and we know that antibiotics affect the microbiome. And antibiotics have been shown to increase the relative rate of inflammatory bowel disease in pediatrics by about 84%. And that's actually a fairly big number. The relative rate increase of the development of lung cancer with smoking is about 20%. So there is a strong association with antibiotics and IBD. Not to say one should not take antibiotics if you have a bad infection, but it's just important to note. And then Western diet. Western diet has definitely been associated with IBD and diets that are high in sugar, high in processed foods, and low in fiber, fruits and vegetables have been associated with IBD. And what happens is your microbiome becomes dysbiotic, so your bacteria becomes angry and mean and breaks down the mucosa or that lining. So now you get these ulcerations in that barrier that keeps the microbiome away. And you have this upregulation of the immune system. So the immune system, which was just there kind of surveilling, has now started to attack the bowels. So how is diet implicated? Well, if diet were implicated, we would have to show that the microbiome, the bacteria in the GI tract, becomes dysbiotic with certain diets. In addition, we'd have to show that their barrier breakdown occurred with different diets. And finally, we'd have to show that the immune system becomes inflamed with different diets. And we're going to talk a little bit about that upcoming. Before we talk about that, I think it's important to kind of remind ourselves of what the intestinal or fecal microbiome is. And this is about 100 trillion bacteria or microorganisms within the GI tract. And that number is pretty astounding. So about, if you multiply the number of people in the world by about 15,000, that's the number of microorganisms in our GI tract. And we want them there because they're actually doing a big service for us. They're helping break down food for us. They're producing vitamins for us. And they're actually protecting us from bad bacteria in the GI tract. So we want the microbiome there. And if we were to look at the microbiome in terms of weight, well, it's about 2 pounds. And so what I tell people is that they can subtract 2 pounds from their scale and feel a little bit better about themselves if they want. But they are about 2 pounds of our overall weight. So in terms of weight, it's a small proportion. If we look at them in terms of the number of cells, they actually become even a little bit more important. So they actually outnumber human cells in our body about 1 to 10. And then if we were to look at that in terms, if we were to look at the microbiome in terms of genetics or genome encoded, it actually is about 3 million different genes. And so in a sense, we are actually walking repositories of this huge genetic environment, and they actually outweigh us by 99 to 1. And who is in each individual's microbiome? Well, it actually varies. Our intestinal or fecal microbiome is truly personalized, so each one of us has a slightly different microbiome. And what they're doing is adapting. They're adapting to you, your body, which is their environment. And they are continually changing and continually adapting. So how is the microbiome and diet interrelated? Well, the way I like to think of it as each one of those bacteria are a different animal. And if we had these multi-cellular animals up here, if we had a tiger, a dolphin, a panda, a bat, a gorilla, and a cow, we wouldn't be surprised if we fed them all hay, that a number of those organisms wouldn't actually survive. And then we would have a plethora of cows. So very similarly, if we just simply looked at these animals in terms of, or these animals in terms of single cellular animals like E. coli or Rhuminococcus canavis, and we gave them a specific food source, there would be an increase of certain types and a decrease of other types of bacteria. So what does the dysbiosis look like? What does the bad bacteria in IBD look like? Well, it again looks different for different individuals, but overall, what we see is a decrease diversity. So we see a decrease types of bacteria within an individual's GI tract. And there are definitely certain organisms that we see less of, like Fecalibacterium promethei, and others that we see increases in, such as E. coli. And we see other things as well. We see an increase in what we call mucolytic bacteria, or bacteria that are able to break down the barrier of the intestines. And we also see a higher incidence of mucosal associated bacteria, bacteria that are getting close to the lining of the GI tract, which can trigger the immune system. So I wanted to talk a little bit also about the question of what's going to be more important in terms of the microbiome, the genes or who you are, or diet. And there are a few really well done studies that actually show that diet is going to be the most important. And this is an animal study by Karmadi's lab, and they looked at diet's effect on the fecal microbiome of 5 inbred species of mice. And why it's important in inflammatory bowel disease is that these mice were deficient for genes that were relevant to host microbial interaction. So the same types of genes that we see in IBD. And they fed them a high-fat, high-sugar diet or a low-fat, high-fiber diet. And what they were able to show was that diet shaped the gut microbiota similarly across genotypically diverse hosts. So it didn't matter as much what your genes were, but really what you were eating. And that most of these changes were reversible, but the abundance or how many of certain types of bacteria were dependent upon the diet history. So what you ate before affects what your microbiome could look like in the future. And this was also shown in people and humans. And this is a study by a group from Israel led by Rothschild. And they too showed that environment dominated over genetics in shaping the human gut microbiome. And they took individuals with different genetic backgrounds, Ashkenazi Jews, individuals from Yemen, other individuals from the Middle East and North Africa, and they looked at their diets in detail as well as their genetics, and they actually showed that environment, with diet being a significant component of that, had a much greater influence on the microbiome. So it's not only the microbiome that's important, and it's usually where we focus because it's such a fascinating area, but the intestines itself is quite important. And if you look at the cartoon on the left-hand side, you can look at the blue layers, and that is a mucus layer that is super important in inflammatory bowel disease. So this layer is about 9 microns thick. You can't see it with your eye, and it keeps the vast majority of the microbiome away from the lining, the epithelial cells in the GI tract. And that's important because if you keep those bacteria away, the immune system, which kind of lies right below the epithelial cells, can't actually respond to them. So that mucus layer is extremely important. And what we know is that certain foods have a significant effect on that mucus layer. And these include foods such as emulsifiers, high-fat, high-sugar diet, carrageenan, caking agents, and microparticles. And the important thing here to realize is that we're not actually usually aware that we're eating these types of food because they're within so much of the processed foods that we eat today. So where is the literature that shows us that these things are important? Well, this is a study by Martinez Medina, and they looked at the immune system in a Western diet. And as we already said, diet can affect the microbiome. So it induced the dysbiosis with an increase in E. coli in CBAC10 mice. And these are mice that are predisposed to developing IBD. But that's not the part that I want to focus on. What I want to focus on is what it does to the lining of the GI tract. And what you can see here is on the left-hand side, it increased Claudin-2. So the picture on the lower side of the Claudin-2 column has increased red dots, and that is the Claudin-2. And what is Claudin-2? Well, it's a pore-forming protein that leads to the proverbial leaky gut. It also decreased MUC2, and MUC2 is a significant component of that mucus layer. So that 9-micron thick layer, MUC2 is a very significant component, and it decreased that significantly in these animals. Again, showing that high-fat, high-sugar diet affects the potential lining of the GI tract. And it would be, again, wonderful if it was just one thing, but there are other things in diet that can affect this as well. And maltodextran, which is a emulsifier in many products, has been shown to do this as well. And what you can see here in the picture is that in the control picture on the left, you can see that the lining of the GI tract, which is green, and the bacteria, which is red dots, are kept away from each other by this black mucus layer. But when you add in maltodextran, you can actually see the bacteria getting much closer to the epithelial and abutting the epithelial layer, again, affecting the epithelial and hypothetically the immune system below it. And this has been shown with other emulsifiers as well. This is emulsifiers called CMC and P80. Again, you may not know these names, but they are in the foods that we eat. And you can actually see in these animals, which are interleukin-10 mice knockouts, that again, the emulsifiers allow the bacteria to get much closer to the epithelial lining. And in this study as well, in these animals that are predisposed to developing IBD, you can see that there's an increased incidence of inflammation in the bowels. So if you look on the right-hand side, the animals that had CMC and P80 were much more likely to have colitis than those fed water. So we also know that diet can affect the immune system directly, and there are a number of studies in this area as well, some foods being more pro-inflammatory, such as wheat germ agglutinin and amylase trypsin inhibitors, and some being anti-inflammatory like polyphenols and isothiocyanates. And this is also an area of significant study, primarily in the basic science world. So then the question is, well, if you have this basic science, how does that actually affect us as humans on a day-to-day basis? Well, there are a number of dietary studies out there, and this is actually still an emerging area of research. The two areas that have been studied best are probably exclusive enteral nutrition and the specific carbohydrate diet. And so I'm going to focus a little bit on these two areas. So EEN, or exclusive enteral nutrition, is actually a mainstay of nutritional therapy in Crohn's disease. And many people may not have heard of it because it is definitely something that is done more often in pediatrics than adult medicine, but it's when an individual with Crohn's disease or active Crohn's disease goes on 8 to 12 weeks of exclusive formula. So all they're drinking is formula outside of water. And they either take it orally by drinking it or via a nasogastric tube. What's amazing about EEN is that it works equally as well for active Crohn's disease in children as steroids. And that's been shown in many studies. But I'm going to highlight just one study. This is a study by Borelli. And if you look on the left-hand side, these are graphs showing how children did. Their clinical activity, meaning how active was their disease. The slope is exactly the same for steroids or EEN, right? And if we look at their labs, again, the CRP and the SED rate, both inflammatory labs, they actually normalize exactly as well for both those on steroids and those getting EEN. But what was different, and this is important, what was different was the mucosal healing. So when an individual was on steroids, the mucosal healing after 10 weeks of steroids was not significantly different than where it was prior to starting the steroids. But when an individual went on to EEN, the mucosal healing was significantly better. And that really points to what's going on in the GI tract and the impact of diet in Crohn's disease. What was really nice was this study was redone by a group in France, and they also looked at the microbiome in addition to the mucosal healing. And in this study, actually, it had 89% of mucosal healing with the use of EEN, which is a pretty significant number. But what they also looked at was the microbiome. And you can see here on the left-hand side, there is a plot that looks at the microbiome before treatment and after treatment. And the microbiome for those on steroids versus EEN were very significantly different. And that may be one of the reasons we're seeing a difference in mucosal healing. So a big question always comes up, is EEN effective in adults? And I will tell you that majority of studies say that EEN is not as effective in Crohn's disease in adults. And there may be a number of reasons for that, but probably a lot of this has to do with poor compliance, meaning that individuals, if they weren't able to maintain on the EEN, would not get the beneficial effects. There are actually 2 studies done that had the adults place nasogastric tubes, and therefore the efficacy was much better. The efficacy in these 2 studies actually mirrored the efficacy of the pediatric studies. So I think in the adult world, it's still a possibility. The question always is compliance. So that kind of leads to the question, can diet have a similar effect of EEN? And that's where the specific carbohydrate diet comes. And this is a diet that's been around for a long time. It was actually started in the 1930s by a physician by the name of Sidney Haas. And then he treated the daughter of an individual by the name of Elaine Gottschall, who had ulcerative colitis, and that child did better. And actually, she wrote a book, and it's been living outside of medicine for a very long time. And this diet restricts grains, restricts sweeteners outside of honey, restricts milk products outside of hard cheeses and yogurts, and food additives. So it really focuses on foods that one can prepare at home. These are whole foods, fruits and vegetables and meats, and a yogurt fermented 24 hours. And we've done a little bit of research in this area and continue to push forward the research to better define the effects of the diet. But I wanted to bring you or show you kind of our journey of studying the SCD. And this is our first study where we looked at individuals in a retrospective manner, meaning that they had done this and then after they did it, we were looking at their effects. And we found 7 individuals who did this on their own. And they all came in with mild up to moderate disease activity. And then were followed up about 3 months later, and their symptoms actually had resolved on a whole. But what really fascinated us, what really got our attention, is what happened to their inflammatory markers. And this is a significant normalization for those that had elevated inflammatory markers, CRP, prior to starting the diet. And so we moved forward with a prospective study. And this was both for Crohn's disease as well as ulcerative colitis. And this was in patients that had active disease but did not change their medications. And we followed them for about 12 weeks, looking at their clinical laboratory as well as changes in their microbiome. And what we found was similar to our retrospective study. There was significant clinical improvement, both in the Crohn's disease as well as the ulcerative colitis patients over that 12 weeks. And we also found significant improvement in their inflammatory markers. So their CRPs, their sedimentation rates normalized as a group, and there was significant improvement in their calprotectins. And what happened to their microbiome? And so, again, as I mentioned, everybody's microbiome is a little bit different. So I wanted to show you this one individual's microbiome to show you the shift. And so what you can see here is that initially this individual's microbiome had significant amount of E. coli and Ruminococcus gannavis. And these organisms are associated with IBD. And you can see over a 12-week period, the percentage goes down fairly significantly. So E. coli at baseline was 12, and Ruminococcus was 15. And by the end, it was 0.2% and 1.9% of their microbiome. And as I had mentioned, everybody's microbiome started at a different point, and so the shifts were very different. And so we didn't see a commonality, but we did see significant shifts all in all in these patients. So we wanted to kind of ask another question. We wanted to find out, was the SCD diet by itself the most important, or could you see similar results with less strict dietary interventions? And so we moved forward with this blinded diet control study. So it was blinded because everybody had a study chef and they produced foods for the patient. And we followed them over a 12-week period. And during that 12-week period, just like our first study, we looked at the clinical outcomes as well as laboratory studies, as well as the microbiome and the metabolomics. And what we found was, from my standpoint, surprising. So we found that the SCD, as well as a modified SCD, which had oats and rice added to it, clinically improved patients equally as well. And we also saw significant improvement in their laboratory studies. with a decrease in CRP and sedimentation rate and normalization for many of these patients. But what surprised me was our third group. This was the whole foods group. So these individuals ate a healthy diet, and we did remove milk and milk products outside of yogurt, the fermented yogurt, and we removed corn and wheat. These patients too improved clinically and actually felt better during the 12-week study. But we also saw a decrease in the inflammatory response for these patients. Not a normalization, but a decrease, which indicates to me that diet is going to be important for individuals, no matter whether they're on medication therapy or not. And then the chart on the lower side here shows the improvements in CRPs for the patient population that we studied. We also studied the microbiome and metabolomics and proteomics in the study, and we did see significant shifts again within each of these groups. But again, because different individuals started at different spots, we didn't always see a commonality between patients. So the question comes, what dietary advice for the individual patient is going to be best? And it really, really matters who that individual is, what is going on with that individual from a clinical perspective, and what that individual wants. But with that being said, I do believe that all individuals should be looking at their diet to decrease the likelihood of symptoms as well as inflammation. And over time, we're going to be able to even better define which diets individuals should be going on. And what's really made me happy over this last few years is the increase in the impact of diet. And there are two multi-center studies that are currently ongoing. One is the PRODUCE study, which is a multi-center study in pediatrics looking at SCD versus a modified SCD. And then the Dying CD study. And this is a study that is funded by the Crohn's and Colitis Foundation, and which Virginia Mason has been a very active participant in. And these studies, as well as many more, will further answer the question, what diet for which patient. So I wanted to come back to our clinical case. This young man went on to EEN and then transitioned to SCD. And he's been in clinical remission and laboratory remission for over 3 years. But I think what's also important is we moved forward with a repeat endoscopy and colonoscopy at that time. And what you can see is that everything had healed up. And he also, on biopsy, had normal histology, really, again, showing the impact of diet for patients. So in conclusion, diet matters, no matter who you are, and it actually matters whether you have IBD or not, because we have to remember there are many other chronic conditions as we get older that can affect us, and it's important as people to not only look at the IBD, but cardiovascular and other medical issues. So diet matters. And with that, I thank you, and I'm happy to take any questions.
Thank you so much, Dr. Suskind. That was a wonderful talk. We do have a few questions here. We're running a little over on time, so I'm going to ask you to be just concise with your answers, but I do want to get through questions. Okay, So the first one is a question about whether you think diet works equally well in Crohn's disease and ulcerative colitis, or are there going to be differences between these diseases?
Yeah, it's a great question, and a question that we don't truly have the answer to as of yet. My general feeling is that we do see a substantially better effect in Crohn's disease patients, but we also see effect for our ulcerative colitis patients in my clinical practice. Lot more research has to be done, and I think the PRODUCE study, which has both Crohn's and ulcerative colitis, will hopefully also answer that question.
Okay, another question is, do you think that the diet therapies are affecting disease activity because we're taking away something bad that people are eating, or because we're adding in foods that are healthy?
Again, a phenomenal question. I think it's both. I think that removing those items that have a negative impact on the microbiome and the mucosal layer is key, but also those foods, specifically the whole foods, fruits and vegetables, have a positive effect. So I do believe that both impact it.
Okay. And then a few people asking how should they get started in regards to diet, because they've gotten a lot of different conflicting information from people in the past. Do you recommend they meet with their GI doctor, a registered dietitian? Are there resources that they could be directed to?
Mm-hmm. Well, again, I think it depends on how an individual wants to integrate diet therapy into their lives. So if you want to eat a healthy diet that is going to promote, a positive microbiome and help with just overall life, a dietitian is going to be the individual I would first go to. If you want to discuss using diet as a primary therapy for your inflammatory bowel disease, such as EEN or SCD, then I would talk with your gastroenterologist in conjunction with a dietitian. And that would help answer the question if diet is right for you. I do have a website called nimble.org, which is our practice at Seattle Children's. But it's going to be also important to talk with your gastroenterologist to make sure that it's right for you.
Great. And we do have a couple more questions here. I'll try to maybe forward those along to you, and you can provide some answers after or at the end of the conference. Thank you so much, Dr.
My pleasure. Thank you.